Today we'll be discussing the case of a 68-year-old male who presented with generalized lymphadenopathy, fatigue, as well as about an 8-pound weight loss. He was otherwise a fairly well male with a past medical history of hypertension that was under control. And on his initial exam, he did have some abdominal distension, some splenomegaly, and also had some palpable adenopathy, especially in the cervical and axillary regions. On his lab workup, he was found to have a normal absolute neutrophil count, but his LDH was elevated at 345. His hemoglobin was low at 9.6, and his white blood cell count was otherwise normal. He underwent an excisional lymph node biopsy of an axillary lymph node, which confirmed by FISH that he had translocation 1114. In addition, the immunohistochemical stains confirmed that he was cyclin D1 positive, as well as CD5 and CD20 positive. As a result, the diagnosis of mantle cell lymphoma was confirmed. He underwent a bone marrow biopsy, which was also positive for involvement with lymphoma, and his PET-CT demonstrated widespread lymphadenopathy in a number of nodal regions. In addition to the cervical and axillary regions, there was lymphadenopathy in the abdomen. In addition, he did have splenomegaly consistent with his physical exam. So ultimately, he was diagnosed with an Ann Arbor stage 4 and had a high-risk MIPI score. His performance status was 1, and he otherwise looked well at the time of his visit, although you could certainly tell that he was impacted by his developing disease. Given the fact that he did have symptoms and the extent of his disease, he was started on chemotherapy with bendamustine and rituximab and completed 6 cycles of therapy. At the conclusion of treatment, he achieved a metabolic PR, but clearly had an excellent response to therapy, and at that time was initiated on maintenance rituximab, which he received every 2 months. He did well for several months, but about 9 months later, he did present with recurrent lymphadenopathy. This was biopsy confirmed to be relapsed mantle cell lymphoma, and at that time he was started on ibrutinib monotherapy, 560 milligrams per day. After the first 3 months of treatment, he completed a follow-up PET-CT, which demonstrated no evidence of residual disease, and at this point he remains on ibrutinib.